Hi, Molly.
Hello. Good morning.
How are you? Nice to see you.
Good to see you.
Yeah, thanks so much for doing this. I'm really excited to hear your talk.
Yeah, no problem.
Are you
Um,
able to screen share and everything? That all works okay?
let me try. Um, just minimize.
Okay, yeah. All right, great.
It looked like the right
Yeah,
view. Okay,
yeah, that's the right view. Yeah.
okay,
Okay.
cool.
Great.
I'll just leave it up, or like, do you want me to not to?
Whatever you prefer.
Okay.
Yeah. What's the temperature like over there? Are you having a cold spell as well?
Yeah, it's like it's cold for here. It's like in the low 30s,
Oh,
20.
okay.
Usually in this winter, it's like in the 40s. So
Okay.
how cold is it there?
Uh, Too cold for words. It's 8, feels like -11.
Oh, yeah,
According to the phone.
yeah. Yeah, it's not that cold, but we're used to when I used to like really bundling up.
Right, right.
But no snow, so I
So
saw
that's a win.
it snowed in like New Orleans or something crazy.
Oh yeah, I think even in Texas it's been snowing.
Things out of whack.
People are just filing in. We'll just give it a minute or two if that's okay with you, and then introduce you and turn it over to you.
Dr. Billings, good to see you.
Hey,
I'm Ron Shervin. I think we've crossed more electronic paths than,
it's true.
than still electronic, but at least it's visual.
Yeah. Yes.
Thank you for coming.
Yeah, absolutely. Good to be here. Is this like interdisciplinary like ours?
Yeah, our sleep center is interdisciplinary, so our grand rounds have uh, people from multiple departments, and then us at the university, and also our colleagues at the VA.
Okay, nice.
Yeah, so there's our faculty fellows and then our APPs.
Okay. Do you all do this before clinic or you don't have clinic on Wednesday?
Um, there's clinic in the morning, so it's after clinic.
Gotcha.
Yeah, but it runs into study reading for a lot of people,
Hmm.
and but people make it work.
That's usually a bit more flexible.
Yeah, a little easier to navigate than clinic. Well, in the interest of time, we'll just go ahead and get started. So, hi, everybody. Welcome to our Sleep Medicine Grand Rounds. I'm honored to introduce you to Dr. Molly Billings, who is a professor of medicine in the Division of Pulmonary Critical Care and Sleep Medicine at the University of Washington School of Medicine. She did her undergraduate degree at Stanford University, followed by medical school at UCSF, and then her training in internal medicine at UCLA and fellowship in pulmonary critical care and sleep medicine at the University of Washington, where she also serves as the medical director in the Harborview Clinic as well in Seattle. So Dr. Billings wears many hats, has many academic pursuits. She's particularly, I think, recognized for her work in diversity, equity, and inclusion, both kind of at large in medical environments and specifically related to sleep health and sleep apnea disparities. She's published a lot on this topic as well. So we're thrilled to have you share your knowledge and wisdom with us today. So thank you so much again for joining us, and I'll turn it over to you.
Thank you so much. It's great to be here virtually. I'm glad I'm not there physically because it sounds like it's very cold. No, it would be fun to go visit you guys as well. So I'm going to just be talking about sleep health in general, focusing on disparities and looking at it through a lens of the social and ecological contributors to disparities. I've got nothing to disclose. So I'll kind of go through how the neighborhood can impact sleep and health in general, specifically the built environment. And we'll discuss how social and the ambient environment features may impact sleep, and then kind of apply this to understanding CPAP adherence patterns and why they may differ by these socioeconomic factors. So just to kind of give you an overview, sleep health, different factors in the social and built environment. So the ambient environment, I kind of think of as things in your surroundings. So like the air you breathe, if it's polluted, if it's noisy, if it's a lot of lights. I was recently in Las Vegas and super bright. And then the heat index, which less applicable right now, but that can also affect sleep. The social environment, so kind of how safe you feel where you sleep. If you don't feel safe and secure, as we all know, it's harder to sleep. And that's probably wired into us. Then there's the built environment, so how our housing is constructed, the streets we live on, how feasible it is to go for a walk. That can all contribute to sleep health as well, and we'll get into that. So sleep health, as you probably know, is a multidimensional construct, and healthy sleep is not a simple thing. It requires you to have enough time to sleep, the right continuity. So as you know, in sleep apnea, you might have enough time, but you still feel sleepy because your sleep is very low efficiency, constantly waking up. The timing, or you're being in sync with your underlying circadian rhythm. Do you feel rested after you sleep? Do you wake up and feel alert? Does it feel like good quality sleep, which is, of course, by nature subjective? And can you achieve this consistently? So all of these things go into having a healthy sleep. Sleep health, as everyone who's experienced unhealthy sleep, which is very common, is essential for wellness. So feeling physically and mentally well is improved by having good quality sleep health. It's been adapted by the WHO as necessary for optimal brain health, and now recently included in Life's Essential 8 for cardiovascular health. And these are things as sleep doctors we already know, but others, it tends to get ignored in medicine in general. I think it's important to bring it to the forefront, and now we have some progress in this. Sleep disparities sort of reflect that sleep health is not distributed equally. So as we discussed, it's biologically necessary and integral for health, but in many cases, it's inadequate. And there's a very strong social component of sleep. So it really can be impacted by where you live, your social situation, your economic situation, and other interpersonal factors. And unfortunately, sleep health has become somewhat a marker of privilege. So in America and in much of the world, if you are poor or disadvantaged structurally, you are more likely to have poor sleep. So for example, in the United States, we know that sleep differs by race and ethnicity. So Black, Indigenous, people of color in the United States have, on average, a shorter sleep duration. Black Americans especially have 2.5 hours, 2.5 times more likely to sleep less than 5 hours, which is quite short. in the BRFSS, the BRFS, as people say, which is a large survey done, consistently shows greater insomnia symptoms in Black, Pacific Islanders and Hispanic and Indigenous communities. Asian, Hispanic, and Latino report less than 6 hours more often, although this does differ by acculturation and immigration status. But this is subjective as well as verified by actigraphy, so shorter sleep in these populations. Then why? As we know, race is a structural concept, so it's not due to any underlying biological factors. It's due to our culture and structural factors that for historically discriminated against peoples that have led to these differences. One may be socioeconomic position. People in lower socioeconomic position more often have a delayed sleep onset, poor sleep quality, and shorter duration of sleep. This is more common in those with food insecurity, without a college education, have more insomnia symptoms. A lot of this may be mediated by neighborhood factors, which we'll get into. And then there's the contribution of your work schedule. If you have to do shift work, you have to get up super early, a long commute, you work multiple jobs, that can all affect your sleep. And this is sort of a rubric by Anna Diesrub, kind of looking at how neighborhood can impact your health. And this is not necessarily sleep, but you can apply sleep to this sort of construct. So the underlying structural factors leading to neighborhood segregation and residential segregation by race and ethnicity and socioeconomics leads to these different neighborhoods that have different physical and social features that can impact how well you're able to sleep and your health. So healthy neighborhoods in general have better sleep, and these can be neighborhoods where there's more aesthetic quality, you feel safe to walk around, there's trees, clean air, you're closer to nature, they have high walkability, they have recreational resources, green space, healthy foods available, sidewalks. Those have all been found to be what we call healthy neighborhoods. Healthy neighborhoods promote people being active. So they're not car centric, which is much of America, but more sidewalks, mixed land loose, so you can walk to the store, you can walk to the coffee shop, you can go to the farmer's market, you can see your friends and connect with your community. So if they have sidewalks in your community, you're more likely to walk and be about half as likely to, more likely to be active for 30 minutes a day. And these features are assessed via GIS or Geographic Information System, so they can kind of use map data to sort of assess how healthy your neighborhood is, how walkable. And that's been associated with lower cardiovascular disease, lower rates of diabetes, and lower obesity. And given we know that all these things are highly correlated with sleep apnea, very likely that these are also associated with less risk of sleep apnea. Sleep health has also been associated with physical environment features. So people that live in neighborhoods with more tree canopy, so more shade, presumably, more leafy green, more sort of pleasant. They have a longer sleep duration. People that live near water features or green space in the BRFSS have a lower likelihood of insufficient sleep. Although there is some complexity to it. So people that live in more dense neighborhoods with the ability to walk around and higher walking score have a shorter sleep duration. And that may be due to some urbanicity and some other features we'll get into. So these are all neighborhood features that affect sleep health. So we kind of talked about sidewalks, tree canopy, access to healthy foods, all being positive for sleep health. And then we'll kind of get into the things that are more detrimental to sleep health. Things that lead to less sleep due to the nature of your environment. So one being underlying residential segregation. And I touched on this briefly, but due to historical discriminatory practices in lending and redlining and sort of labeling different neighborhoods, that has led to groups being placed in economically deprived areas. So undesirable locations, and these neighborhoods tend to be less healthy, and they tend to be predominantly minority and immigrant populations initially, and then also historically discriminated and marginalized groups of people. So this is a map of Philadelphia, and you can see it's highly segregating. The different colors correspond to different racial and ethnic groups. I didn't do Ann Arbor, but I looked at Detroit, which is also extremely segregated city. This is from the 2020 census, and each dot represents 25 people, and it's color coded by race. And you can see that the redlining is very evident from over 100 years ago when that was put in place, but still very segregated. And it's true even in Seattle. It's true most of America. So there's higher concentration of people of color in certain areas, and they tend to be in the lower socioeconomic position neighborhoods. And the white population, as you can see, is sort of more along the edges, close to the water, which is, more walkable, more healthy neighborhoods. And this just shows the map of neighborhood socioeconomic status, and you can see it closely parallels the distribution by minority status, with the African American, people of color being more dense in the most disadvantaged neighborhoods. These are also what we would call the obesogenic neighborhoods. So the opposite of the healthy neighborhood, where you can walk and visit your friends, are the sort of car-centric neighborhoods that promote you driving, promote you staying at home, and promote poor dietary habits. So these are your food deserts, where when you can go get is the drive-through Burger King or Wendy's. They have higher rates of obesity, higher rates of cardiovascular disease, and most likely also sleep apnea. And so you can see that there's definite differences in BMI in similar neighborhoods where there's more economic deprivation. And these are neighborhoods where there's streets like this, where it's all strip malls, and you really don't want to walk on that street with busy cars driving by. We talked a little bit about how tree canopy can improve sleep. There's also inequity in tree canopy distribution. So this is Seattle again, but you can see that it's much more green and leafy and more shady trees in the wealthier areas, the more white predominant areas, and kind of tracks with socioeconomic status. Detroit, similar pattern. Not many trees in the poorer areas of Detroit, where there's more economic deprivation. This leads to and contributes to the urban heat disparities. So we know that there's more urban heat in areas with less trees and more like asphalt and cement. And if you look at where those areas are, they tend to be concentrated in these different areas of economic deprivation. So in the redlined areas, this little graph shows the different color coding of different areas for purchasing home and getting loans. And the redlined areas are marked in red here, Group D. Those are the historically deprived sort of housing areas. And those are the same places where it is very hot at night. And so it's worse, obviously, in the summer. So the elderly and the people that can't afford air conditioning, they're the ones that are going to have really high temperatures trying to sleep at night. And that obviously can negatively impact sleep. In Seattle, similar story, similar distribution as before, concentrated heat in these areas of greater deprivation and more people of color, which is hard with climate change as people don't own air conditioners here. And so it's very hard to cope with the heat, and that can impair sleep quality and likely get worse. Disadvantaged neighborhoods, as we talked about, are the neighborhoods with less economic resources. So people tend to be poor, things are in more disrepair, and this can induce more psychological stress. People are not walking as much, they feel more afraid, they tend to have lower sleep opportunity and quality, more time, more daytime sleepiness, more delayed sleep onset. And this is both subjective and objective. And this is actually from the University of Michigan in the Flint adolescent study. This kind of trickles down to kids. So pediatric sleep health is also similar patterns to adults. So neighborhood disadvantage, specifically living in lower socioeconomic neighborhoods, is associated with sleep apnea and also associated with poor sleep in those kids, or sleep quality, longer awake after sleep onset in more disordered neighborhoods. And that kind of brings me to the social environment. So, do you live in a wealthy neighborhood, or do you live in a neighborhood where you feel less safe? And that tends to be in more poor neighborhoods. If people feel connected to their neighbors, if they've built trust, there's more cohesion, and that usually helps people feel more safe and sleep better. So if there's less social cohesion, that's associated with shorter sleep duration. And then perception of safety. So if you feel like there's a lot of violence in your neighborhood, you feel like you need to really lock your windows and doors, and there's more crime, that's associated with lower sleep efficiency, more insomnia symptoms, and worse quality sleep. And then there's the ambient environment. So sounds and light can disrupt sleep. So more insomnia, more difficulty sleeping, not surprisingly, in really noisy neighborhoods with more sirens and just loud sounds outside. Similar with a lot of lights that can suppress melatonin and shift circadian rhythms, and so people have more delayed sleep. Air pollution is one of my interests, and not surprisingly, there's also a difference in distribution of air pollution. And in general, there's just more pollution on the East Coast. But it also differs within US metropolitan areas by where you live. So if you are in a highly segregated area, you're going to be exposed with more racial segregation. You're going to be exposed to higher levels of traffic-related air pollution and other pollutants. So one of my interests was how these features might intersect with sleep apnea. A lot of the studies have been on just sleep health in general, and sleep symptoms, sleep duration. But I was looking to see how this might impact your risk of sleep apnea. And I kind of touched on a lot of these features, but this is sort of putting it together into a social ecological model where sleep apnea and poor sleep being at the center due to all these different factors. And we mostly touched on neighborhood and social cultural factors, but of course there's things within you, your own health and your family situation that can impact your sleep and risk for sleep apnea. So as I mentioned, air pollution is higher in certain neighborhoods. And we know that exposure to air pollution has negative consequences for your cardiovascular system and your respiratory system. There's more upper airway edema and congestion, more asthma and COPD. And higher levels of air pollution have been associated with, in some studies, higher AHI and worsening hypoxemia in summertime, more rates of snoring with higher pollution. A study in Thailand found indoor rates of air pollution, so particulate matter, associated with more severe sleep apnea. I did a study looking at using the MESA data, which includes 6 US cities, and has very diverse communities and populations that were all at risk for cardiovascular disease. And then we used the sleep data, which was about 10 years from the initial onset. And that did sort of a cross-sectional look at people's rates of sleep apnea. And this was kind of my hypothesis that higher levels of air pollution and your neighborhood environment might contribute to your risk of sleep apnea. So the Mason neighborhood study kind of looked at the neighborhood features of the folks enrolled in the study, looking at one of the questions looked at their walking environment. So as I mentioned at the beginning, if you are able to walk and feel like your neighborhood's pleasant, to go out and do things, you feel safe, all those things contribute to how walkable your area is. There's sidewalks and places to go. And we kind of looked at an area about a mile around their house as to relate to their sleep apnea risk. So the cohort was pretty large, but a smaller number had sleep studies done. And then we kind of looked at their exposure to air pollution and their rating of their neighborhoods. And the pollution models used a lot of different things to kind of get a more specific exposure to this particular person. So what was in the air, the emission sources, kind of the topography, and kind of factor that in with their precise residential location. And this was back in 2010. We had in-home full PSGs as well as wrist actigraphies. And there are about 2,000 people that completed this study. As you can see, pretty diverse group. Only a third were white. And then a good proportion had sleep apnea with a median HI of around 14. And so we looked at their exposure in the prior year to air pollutants, and with each increase in nitrous oxide, which is traffic-related air pollution, there was a 39% increased risk of sleep apnea, and similar with particulate matter, higher risk of sleep apnea with more particulate matter exposure. Walkability was similar if you did not live in a very walkable environment, so you rated it poorly, that was associated with a higher AHI, adjusting for typical factors associated with sleep apnea. And particularly if you were obese and lived in an environment where you didn't like to walk, you had a much higher risk of sleep apnea. And we know that walkability is associated with sleep apnea in that if you have people walking and do randomized control trials where people are encouraged to walk, they do have less sleep apnea and less sleepiness. And this has been also confirmed by objective measurements of walkability using GIS data, and that was also associated with sleep apnea. So just to summarize, these are different features of your environment and how they might impact your sleep. So better sleep in general with more green space, more water, poor sleep with lower social cohesion, more fragmentation, feeling less safe, and then more noise and air pollution are detrimental to your sleep. And few of these, as you can see, have been studied in sleep apnea per se, but if you look at BMI as a proxy for sleep apnea, a lot of them are associated with the risk of sleep apnea. And so this is sort of a way to put this together, how where you live is segregated by race, ethnicity, socioeconomic status that sort of impacts your environment and crowding, safety, social factors, and that affects your risk of obesity and how active you are. Other features may impact your sleep as well, and that can lead to more lower sleep health due to sleep disruption, delayed sleep, insomnia, and increasing risk of sleep apnea. Okay, any questions so far?
I don't see anything in the chat so far.
I
Oh,
have a question.
yeah.
You know, so thank you for reviewing a lot of these studies. It's a lot of literature, and it has stricken me, you know, for a while that it's so complicated to take to derive the cause and effect and arrows of directionality
Yeah.
in these data. And you know, I'd be interested in your opinion about how much have we accomplished it? I mean, do we know what the root causes are or the pathways are? For instance, I'm sitting here thinking, well, how does the pollution relate to OSA? Well, maybe it irritates upper airways, causes inflammation. I don't know that we've proven that or shown it or to what degree we have. And I especially am not sure I understand completely what drives the sleep deprivation in these neighborhoods. And is it, you know, I think you rate all the things you put on the table could well be influential, but I'd be interested in what you think. And also if Dr. Dunetz is on, she works in large data sets and does causality models. Anybody, I'd be interested in thoughts.
Yeah, I think you raise a good point. It is certainly more complicated than my my little conceptual model here. There's a lot of things going back and forth. And yeah, I think some of it is some of these features, but certainly there's a lot of things in your own environment where you live that might impact how well you sleep. And I kind of mentioned, but you know, if you work a job where you don't have opportunity to sleep or you're working night shift, all those sort of factors also, in addition to your environment, contribute, as well as your own personal stressors that's going on in your life. So it's definitely a lot more complicated than I put forth here. And in terms of the air pollution, yeah, there hasn't been a lot of study, at least not that I've seen, on the etiology of it. I kind of thought it was, as you mentioned, you know, inflammation in the upper airway with more congestion, sinus disease, edema. Um, but probably it's more than that. There may be some effects in the brain, and regulation, stabilization of sleep, also hypothesized. But I'd be interested in other people's thoughts as well. Go ahead, Ellen.
Hi. You know, one of the things it's a very interesting talk, and relative to Ron's question, one of the things I've learned since spending time in a psychology department that I didn't know before is this whole technique of structural equation modeling. And I'm wondering if that might be useful to it with these kind of data, one kind of structural equation modeling to address the question that Ron raised.
Yeah, I think that would be useful. I think we did that, or others have done that. I don't think I did that in my study, but others have done that, to look at some of these complex factors. But it's been a while since I've thought about that stuff, so I will defer to others. But yeah, I agree that that's a good way to model all of these different factors.
And when you think about it, this question is not going to be answered by a randomized controlled trial very soon. So,
But yeah, and you're not going to randomize people to live in certain neighborhoods, and you know, you just can't do the studies. So you have to use natural experiments, but yeah, there's always the caveats with that as well. So yeah, it's very difficult to unwind for sure. Any other comments or questions?
I think a lot of this also has to do with industrialization. I think like there's, poor neighborhoods near factories, railroads, lots of noise pollution. I'd be interested in seeing what the carbon footprint of making all these CPAP machines is. Do you know if any like environmental studies done on like I guess, I mean, it's probably like a microchip industry as well, but
Yeah,
there's some sort of irony to it. I feel like we're making all these machines, all these factories, and then polluting the air that might, in effect, also cause all these problems. So,
yeah, true.
Right.
And all the masks and stuff that we
mm,
put through. Yeah, that's true. Yeah, especially with the recall and all that. Yeah, there's lots of layers. All right, so I'm going to shift gears now and talk about CPAP use and how we can apply some of these concepts to understanding different patterns of adherence. So this kind of dates way back to differences in CPAP use that I observed in a study I did a long time ago. It was a randomized control trial looking at different models of getting people started on CPAP, which kind of was at the time novel, but now we know you can do home studies and people do just fine. But anyway, in this study, we noticed that people who were self-described Black race had a lot lower use of their CPAP after adjusting for all the factors, and they were in a randomized trial, so everything was provided. And it was quite a big difference. It was an hour less use. So I was trying to understand why that was. Part of it we could see was due to shorter sleep duration reported by some of these folks, as well as longer time to fall asleep. So that may be contributing to, it's hard to sleep, so you're not going to want to wear your CPAP. We saw that sleep habits did differ a lot by demographics in this study. People, as kind of I noticed at the very top of the talk, people in this study reported less sleep if they were a Black race and a longer sleep latency. And that also was correlated with education and where they lived in terms of sort of how the socioeconomic status of their zip code. So that kind of got me thinking about all these different factors, and we touched on a lot of them for sleep health, but they also likely impact CPAP adherence. I'll kind of go through these different contributors, and certainly this is not exclusive, but these are just some of the socio-ecological factors that can contribute. So one being discrimination. Discrimination can be race-based discrimination can be institutional and structural, and that can be sort of how we approach and how we think about sleep in different groups. It can be interpersonal, so like microaggressions, macroaggressions, and internalized racism. Studies have shown that experiencing racism and discrimination is associated with insomnia, shorter sleep duration, and poor sleep quality. In the sister study, the women that experienced discrimination had shorter sleep and more insomnia symptoms. Sort of race-related hypervigilance is associated with sleeping difficulties. And we know that experience racism and microaggressions every day leads to stress, which can impact your sleep. There's also the structural or institutional racism that's built into the medical system and the implicit bias that a lot of healthcare workers have. That can lead to mistrust. There's also a few in general sleep providers, but definitely a larger lack of underrepresented minorities in sleep medicine. And so there's a really lack of concordance in sleep provider with the patient, which may lead to mistrust and people being less likely to stick with the challenge of getting started on CPAP. And there's the effects of segregation. I talked a lot about this already, how that can influence sleep health, but studies have borne out that if you live in neighborhoods that have lower socioeconomic position, that are predominantly non-white, so very segregated, living in neighborhoods with 25% or more Black or Hispanic residents, if you look at a large data set looked at, I think it was ResMed or Respironics data. So looking at pool data of the United States, found CPAP adherence did differ dramatically by zip code. So those that lived in more minoritized, segregated neighborhoods had much lower CPAP use than those that lived in predominantly white neighborhoods. And of course, since this was a large study, they didn't have details about the people themselves, just where they lived. But that sort of hints that this structural factors in their residential area may impact their sleep and may impact, therefore, because they're not sleeping well, may impact their CPAP adherence. So you have more stress, more anxiety, there's more crime, there's more noise that may lead to fragmented sleep, delayed sleep, inability to fall asleep, difficulty getting to sleep, some more insomnia. And then the more aware that you're wearing this CPAP thing on your face and you can't get to sleep. And so you just sort of give up or don't use your CPAP for as long. There's also, of course, access factors. Those are big systemic factors that may contribute to lower PAP use and disparities. So we know studies have borne out that in Black versus white adults, there's a lot lower recognition that people may have sleep apnea. There's lower follow through, getting tested and treated. There's lower rates of sleep professionals in general, but especially in federally qualified health centers. So those folks that are the most high risk and living in poor areas may not even be tested or treated. And then once you get your CPAP, there's just going to be harder to get follow up. There's also the digital divide. So people don't have broadband Wi-Fi in a lot of these areas. They don't have digital literacy to use the apps on their phone. They may have language barriers. They have lower health literacy. And then there's sort of their life situation where they're working rotating shifts or nights or long commutes and less sleep opportunity. And then it's difficult to get places if you don't have a car. And might need to depend on others to get a ride or have to care for your children. And that can all impact access. So how can we change this? And so this was sort of work that I did with the ATS to sort of think about these barriers and really think about what we can do to improve CPAP adherence and reduce disparities. Because as you all know, if you don't use your CPAP, a lot of times the insurance won't cover it, and then people don't get treated at all. So how can we help reduce that difference and allow people to continue to use their CPAP and help them have better adherence and hopefully then better sleep health, better health in general. And so the things we came up with were kind of thinking about patient-centered targets for use of their CPAP that accounted for their personal situation, their life, and identifying barriers early, and then kind of dealing with these kind of comorbid issues that come up a lot related to insomnia, related to PTSD and anxiety that are more highly prevalent in these communities. And of course, this has issues, the solutions have issues too, which is, of course, access to CBTI, but that may be very helpful, providing desensitization, getting more mental health providers, and giving folks more time because of these access constraints that I spoke about. Timely communication with DME to address kind of simpler issues that can be adjusted, such as no mask fit, pressure changes, and sort of streamlining that so that can happen more quickly and get people a longer chance to, or a quicker chance to fix the problem to be able to keep using their CPAP. And then engaging the communities these folks live in. So building partnerships, using cultural mediators, using peer buddies, family support coaches to help folks kind of understand their equipment, why they might need to wear it, and how to sort of troubleshoot problems, keep them accountable. And then a lot of the apps and materials are only in English, so providing translations And then the most kind of big thing I think that might be the most helpful would be programs that incentivize care in underserved populations that may require more time and resources. A lot of DMEs, I feel like, or companies in general, have the sort of pressure to focus on areas where they might make the most profit, right? So they're profit driven. So if there's somebody that's going to need a lot more time, use a lot of equipment, they're not going to make as much money. So they're going to kind of pick and choose the easier, quote, easier patient that's quick to get started and doesn't need a lot of time. So sort of incentivizing the DMEs to have a more broader treatment and sort of work with people that may struggle, and with innovation grants to improve access and kind of increase equity. Did you have a question, Dr. Sherman?
To ask you about peer buddies. I
Yeah.
saw a paper on that just recently, and but it wasn't applied to this situation. Is anybody tried to address disparities or, by setting up a peer buddy system, sleep center or clinic?
I didn't see one. I know that they've tried peer buddies in general, and that has been found to be helpful in just like a general sleep clinic. And I think I'd say the VA maybe did as well. But yeah, not in this context. So obviously it does need to be studied to be proven to be effective, but cultural mediators and other things for other diseases, like taking your HIV meds and other things that require adherence, that has been used. So you kind of could move it over to CPAP. But yeah, not to my knowledge. And then there's the larger kind of macro structural things that we need to change. We're making progress on this, but it's going to be a continued challenge to improve the public health of our general population, and especially those that live in these neighborhoods that are most disadvantaged. So expanding broadband, improving transportation infrastructure so people can get the bus or take the light rail or something more feasible that's safe and quick. And then fostering healthy neighborhoods. That's kind of one of my things that I think is important, but of course requires, urban planners to get involved and larger policymakers and politicians. But making your neighborhoods, of all neighborhoods, have parks to go to, have walkable, pleasant places to go, have trees, plant trees. And these actually have been shown to reduce violence, improve sleep quality, and that can also foster more social cohesion and improve sleep in general. So in conclusion, there's epidemiological evidence that shows how these socio-ecological features can explain some of this disparities in sleep health that we observe. And these may drive differences in sleep quality and quantity and your risk of sleep disorders. And certainly these features can impact how well you can utilize treatments for insomnia or sleep apnea, if these sort of environmental features are persisting and causing worsening your sleep. Also, I want to emphasize that public health interventions, which can improve health, in total, not just sleep health, but can improving your neighborhood environment, reducing pollution, keeping it cooler, planting trees, can just improve the population health in general. A small part of that may be improving CPAP adherence, but there's broader benefits. And that's pretty much it. I just wanted to note some of the folks I've worked with in the past on these studies. And yeah, I'll let it open for questions. Thank you so much. I'll stop sharing.
Great. you so much, Molly. That was fantastic. Ron, did you have another question?
I'll defer since if anybody else didn't get to ask theirs yet, but I do.
I have one, but Galit, did you have a question? Molly, I just thank you for that talk. I had a question about, in response to things like Peer Buddies and other things, like how much do you think that falls on a health system versus collaboration with patient advocacy organizations? Like who's better and more equipped at doing this and facilitating and getting buy-in from patients and other supporters?
Yeah, that's a great question. I mean, I think it's a tall ask for, I think, most things to add that to, especially our burden as healthcare providers, because we're already kind of limited and constrained with time with patients. I think it's sort of in the best interest of the patients and maybe the payers of their healthcare. It kind of depends on the system. I know that if you have like an integrated healthcare system like the VA or Kaiser, for example, then the payer itself may be interested in building these, which can help their community's health and improve adherence. So I think the payers are the most likely to do it. In like our system where we don't have anyone really looking out for the patient, it may be in the DME's best interest because then they get paid more because they keep using their CPAP. So they may be ones to organize some of these peer buddies. I do think it would be lovely if we had the time to, as healthcare providers, to help do this. And I know the studies have originated with the healthcare providers, but I think it is not as feasible to implement across different systems, given that we don't get reimbursed or anything for it, and there's really no incentives other than just being a caring physician. But that there's still time constraints. So yeah.
Thank you.
Any more questions?
Yeah, I'd like to talk about education for a moment and where you think that plays a role. We were invited by JAMA Ethics to write a sort of a commentary thing on sleep disparities. How can you address them? And Dr. Dunetz was the first author, Dr. Jansen is not on, but when we thought about it, we didn't think that relying on these big social changes that might be needed is going to yield results very quickly, especially if you're considering a worldwide perspective, let alone here. But we thought that education might be more attainable, and both with respect to the sleep duration, sleep habits, good sleep hygiene questions, avoiding sleep deprivation, and on the one hand, and even CPAP and sleep apnea on the other hand. So that might be more affordable, but how do you get it out? How do you do it in an effective way? I work closely with Devin Brown, who she practically assures me that education doesn't help with stroke patients to improve their adherence. I think that personally, what literature I've seen says that it helps some, but not as much as you'd hope. Oh, and one other thing I'll mention is, we've worked for 2 decades now with Sweet Dreams, and then they were bought by the Pajama program, which is totally based on educating children and families, even from young preschool ages, for example, in Head Start programs, about the importance of sleep, what good sleep habits, consist of. We did a study, we published it maybe 10 years ago, that showed a difference that, a month later that kids were getting a half hour more time in bed. Then we tried to do a bigger study in Head Start programs in New York. Karen Bonock led that effort. And we alternated schools and did it that way. First intervene in one set, then intervene the other set, but then compare those where we had intervened or not. And unfortunately could not show that we extended duration. So what are your thoughts about that whole question? Is that where to sink our efforts, or is that
Yeah,
just
I
as
think, yeah, I think it's worth putting some effort into education for sure. And educating probably earlier, like as I was mentioning, that sleep kind of gets overlooked in general. So even like in medical school, there should be more sleep education because people don't ask about it. In primary school, like you're saying, in kids, educating about the importance of sleep is probably minimized. And so I think it has to start younger and giving people opportunity for more sleep and sort of, and I kind of always look at the policy, but later school start times has helped, right, with kids getting more sleep. So educating the kids, allowing them to get more sleep, and then translating that into policies and how we expect employees. There was studies during the COVID pandemic, right, that showed people got more sleep because they didn't have to commute or anything like that. So ways to improve sleep, I think, are more than just educating, but allowing, implementing policies in the workplace or in schools to allow more sleep. And then the whole making the environment more feasible for sleep, which is a bigger ask. But I do think there is a component for sure of people understanding sleep and knowing that sleep's important and valued. And even though these like healthy age thing for cardiovascular disease seems kind of, lame, at least they're mentioning it, and it's been overlooked for forever. So I think that will be part of like the broader public health campaign that maybe we'll get outreach to more people to like at least have it on the list of things besides blood pressure to improve your health. And now that it's part of the WHO for the healthy brain, I think all these little things may kind of improve education about, or at least put it to mind for sleep, to ask about sleep when you're checking with with your primary care doctor. They ask about blood sugar and weight and exercise, but nobody ever asks, or rarely did they ask about sleep. But kind of making that more part of routine care, I think, will go a long way.
they all go together.
Mm-hmm. We're all believers, but yeah, getting everyone else to buy in.
Big issue. I remember people looking at some group, and I can't remember who it was going into neighborhoods were predominantly, segregated and Black, to barber shops. They went into barber shops and talked to people about sleep apnea, and they just found that a lot of people didn't really believe in it.
Yeah.
Believe that it existed or was a real problem.
Yeah,
So-
that's also, yeah, there's definitely, community perceptions or different groups have different perceptions of healthy sleep. And, some people perceive if you snore, that means you're having a good sleep. So, yeah, I know that
Exactly.
the AASM has tried to put a campaign out to sort of do outreach to at-risk communities that may not know about sleep apnea, and explain potential dangers. And yeah, kind of getting at the community level, not because as I was talking about, their doctor might not mention it, but if they know that, hey, if I stop breathing in my sleep, that's not great, they might bring it up in their primary care visit. So yeah, doing that community level work also, and then maybe teaching about it in school might be helpful. I was pretty excited at our children's museum a long time ago. I took my kids and they had a whole little room with a picture of someone sleeping, and I showed that little image of the sleep apnea, and I was like, oh, wow. look kids. So I thought that was cool. At least get that information out there. Any other questions or thoughts? Ideas?
See any other hands up or any other comments in the chat, but thank you so much. Clearly a really important topic, really engaging conversation. So thank you for joining us today.
Yeah.
It was
Thank
fantastic.
you.
Thanks for having me. Good
Thanks.
to see you all. Take care.
Bye-bye.
Bye-bye.